One clinical question, and a guy in UK had a OG junction growth, and histology-wise, it is a very poor response to chemotherapy, what they discussed. But the patient there, they have discussed everybody, finally they want to put on chemotherapy. The patient put a question, if chemo does not work at me, if it has become advanced, right now imaging shows no nodes, only bulky growth, and if no response, it is your bad luck. We can't help it. That's why you get told. And then finally that guy contacted here came. I did Ivor Lewis and no single node positive. And the growth, of course, it is a bulky growth. He bled and hemoglobin dropped to 5, fell down. That was made him 41 years, got diagnosis. Now this is very difficult to predict these type of things. And sometimes we have to tell the patient gives a concern, then you have to go through that.
One last question, sir, if I may. So similar to the question what Dr. Pallinvelu sir has said, if suppose the patient has a dysphagia, OG junction growth patient having dysphagia and progressively increasing dysphasias, let us say, and let us say is a T3 stage and maybe few lymph nodes which are picked up on the CT may be positive, may not be positive, this scenario, would you still advise a neoadjuvant in such cases? Or what would happen to these patients if you put them on neoadjuvant, and then what happens to them progressively, the dysphagia in the following days?
Okay, so the first point is that in order to alleviate dysphagia, you could do a stent or any one of those procedures that can temporarily help that patient overcome this problem and will be able to eat. I think the more important point as far as you as a surgeon is concerned, so is this patient going to respond quickly to neoadjuvant? The answer is yes. Most of the time they respond. I'm not saying every time they will respond, but majority of patients would respond and the dysphagia will get better. The problem will be if somebody comes to you with already poor nutrition because of the dysphagia, you've lost a lot of weight, you're really not in a position to get to, then I think you should take Dr. Sunita's help. That is a patient who is a good patient for chemoradiation therapy because he is not in a position to undergo a major resection now because of his poor nutritional status. No, he said G junction. Okay. So he is not in a position to undergo big time surgery. He's not in a position to undergo FLOT. So she will be able to handle that patient better with radiation therapy and weekly small doses of paclitaxel. That will alleviate the dysphagia faster. And as I said, in a situation where you think your patient cannot take FLOT, that's certainly a very, very acceptable alternative in a situation like this. That's what we would do.
Yeah, it is also squamous. We always consider OG adenocarcinoma. There are squamous cell carcinoma also do come. Squamous responsive to chemotherapy is there adjuvant, you can go ahead that way. But adenocarcinoma obstructed, as you said, unless it is not fit for surgery, and you can proceed with the surgery.
What would you do, sir? If the patient is fit for surgery, what would you do?
The OG junction growth, it depends on is it type 1, type 2, type 3. You have to make it more of if you need a gastrectomy part along with that, then may Ivor Lewis. And otherwise, Mekion, we can make it anastomosis in the neck.
So you would like to do the surgery upfront or do like
yeah, that's why adenocarcinoma obstruction upfront and front.
So the point is, so just to make it simple, you're not doing disservice to this patient by operating upfront. That's the important point. So it's okay to do because, as I was telling Dr. Fani, that we don't really have high quality evidence to say that you suboptimally treated this patient because you did surgery. So that's very important.
Senthil sir, last question. Few patients perforating who are on neoadjuvant therapy. Just
unfortunately, at least me, Dr. Pratap Reddy, we have not come across that situation.
Two cases I have seen, sir.
That's a little unusual. I hope they didn't use some bevacizumab or any one of those pro-perforating agents along with the neoadjuvant. At least, in our experience, we have not had any perforations with chemotherapy for, epithelial carcinoma. Of course, lymphomas have rarely perforated, and our people really do a great job salvaging all of them. So that's a possibility, but at least as much as I can remember, we haven't had a adeno or a squamous perforating. Maybe, sir, you may have more.
Only in perforation, mostly in lymphoma type populations. Adeno and squamous cell normally no. If you think perforation are too advanced, by the time lung and liver get into trouble. And that side effect all will be there. That's where you look at very important.
In adeno, in 2 cases we have observed.
Yeah. Upfront surgery are not individualized. Patient, you choose that patient's fit and surgery to be done. And now, previously, all neck anastomosis nowadays, Ivory is becoming almost 50% our series. That depending on individual patient, we can do it.